Thank you so much for having me. Really glad to be here in Egypt. Thank you for the invitation. So I have no financial disclosures. These are essentially the clinical trials that I participated in that related to EVAR, and I'm also the national PI for the thoracic endograft relay for Terumo. So at least in the US, it's pretty common problem, 13 leading cause of death and over 15,000 deaths a year. A lot of patients have these aneurysm, and many of them go undiagnosed. Only vascular surgeon knew who that person is. This is really an early picture of him when he was younger, but he essentially came in with abdominal pain, and there was a surgeon there who was not very famous at that time. His name was Nissen. He tried to wrap his aorta with cellophane paper to slow the growth of the aneurysm. And that actually worked for a few years. And then Albert Einstein came back. This is Albert Einstein, came back, rupture. And he was offered repair at that time. By that time, DeBakey had already replaced aorta with Dacron graft. Albert Einstein said, I want to die elegantly, essentially. Very different today. In the US, at least, people want to live forever. We operate on people when they're 90-year-old and we fix their aneurysms. So Juan Parodi...
Recording in progress.
Juan Parodi is at least the first person to document an EVAR. And the first time he sent that paper to Journal of Vascular Surgery, it was rejected from the journal. There is a Russian surgeon also that have done this but did not document it before. But essentially, Frank Vieth, I was really honored to be trained by Frank Vieth, and he brought in Juan Parodi from Buenos Aires, and they did the first EVAR in 1992 in the United States. Many randomized trial. Vascular surgeons know these trials very well. The first one was the EVAR, which is the bridge trial that shows essentially twice as many number of deaths postoperatively with open repair compared to endovascular surgery. And but there were also more re-intervention early on with EVAR compared to open. And then this was followed by the Dutch trial, DREAM trial, that actually showed a similar outcome, a lot more death with open versus endo. It was not statistically significant, but there was a lot more intervention at the cost of more re-intervention with endovascular repair. We actually were tasked to kind of interpret the results of OVER. OVER was the biggest randomized trial in the United States comparing open to endovascular repair. And OVER actually had similar mortality difference. So there were a lot more mortality in the open versus endo. But with the OVER trial, they included hernia repair as part of re-intervention with open. And once they included hernia, incisional hernia repair, there was no difference in the re-intervention rate between open and endo. So that was the first randomized trial that kind of showed no difference in re-intervention. We went out to see, okay, well, these are randomized trials, right? You pick the patient very carefully. They have to be perfect. So the outcome might not be real-world outcome. So we went in and used the American College of Surgery NSQIP data. We published this in JAMA. And we looked at the about 20,000 patients who had a repair. 1/4 of them had open repair, and the rest got endovascular repair. And every year of the study, as you can see, the open repair has higher mortality, post-operative mortality, that is. The mortality rate was 1.3% for EVAR, compared to OVER, it was only less than 0.5%, so that was not really real. It was very, very low number. The 1.5% is more real, and the open repair have similar. So really, these numbers also apply in real-world data. And essentially, you see here that there's 70% reduction in mortality for EVAR compared to open. We also essentially looked at our own experience when I was at Hopkins for 14 years. We used the Giles, Christine Giles created that model to predict mortality based on what really happening in real world in the United States from Medicare data. And we used this model, applied it to a 500 aneurysm we did. And our predicted mortality should have been 20%. But the actual mortality was 2%. And it's not because we're a great surgeon, it's because we have a great institution, great anesthesiologist, great nephrologist, vascular medicine specialist. So we attributed this that the rescue phenomenon, essentially. Our complication rate was not less, but the identification of the complication was faster, and rescuing the patient was better, and this is why our mortality was a lot less than what we predicted. From that moment, there was many trials that actually led to the approval of many devices. I was participating in this device, the Pythagoras, and has really great outcome. This is designed for very angulated neck, 90-degree angle neck. The Ovation device, also we published recently the 5 years outcome, and this device can work even in a 6-millimeter neck. So we are pushing the envelope on the indication for endovascular repair. Then along that time that we start seeing a lot of the long-term outcome. So the first trial, the OVER trial, actually published their 10 years outcome. And you can see here that there was still no difference in the mortality between open and endo at 10 years. You see this in the curve model and the Kaplan-Meier. And there's a systematic review here of many studies that also looked at open versus endo, and you see here the re-intervention rate is a lot higher with endovascular repair. And you see that favoring in the bottom. And also you see that the mortality has no difference at 10 years. The rupture rate, however, was much higher after EVAR compared to endovascular, up to 10 years of follow-up. So we went out again, finally, this is kind of the final piece that I want to show you. We actually did this study. This is very recent. It recently got published in JAMA. And we looked at long-term outcome on open versus endo. We used the Vascular Quality Initiative, which now have more than 1,000 institutions in the United States that participate. The problem with VQI is the patient don't show up for follow-up, or at least we don't enter the data. So the long-term follow-up is very poor. So what we did to overcome this problem, we linked the Social Security. Every person in the United States have a number identifier. We linked it to Medicare, and for people who are not from the U.S., they don't know what Medicare is. But this is the mean that the United States paid for all coverage for insurance for the elderly, which is almost 90% of all vascular patients we take care of are over the age of 65 when they have aneurysm, and they have Medicare. So and nothing happened in the U.S. if you don't pay money, just like anywhere else in the world. So you can get the follow-up very accurately. So we linked the Social Security between VQI and Medicare, and we are able now to get very good follow-up. And so
One minute left, Mahmoud.
We presented, no problem. We looked essentially at 6 years, and the two groups were very different, right? People getting EVAR older, sicker. We did propensity score matching, and you see on the right side, they became very nicely matched group. And essentially, we found that, again, for the first time, we're able to show that mortality rate is actually higher with EVAR long-term compared to open. So this is different than any of the prior study that is published. And the rupture rate, similar to prior study, is higher, and the re-intervention rate is higher. Post-operatively, again, it's always higher mortality for EVAR, but long-term, it sounds like we are losing the benefit, and we're losing it around 2 years. So in conclusion, every study that you can look out there is going to show you that there is less operative mortality with open versus endo. There's no question about it. It's minimally invasive. There's a lot less complication. But it seems like that benefit is last around 2 years of follow-up, where the long-term mortality become higher for EVAR compared to open. And essentially, there's a lot more re-intervention. So I really urge you to follow these patients very carefully, because they might have a lot more complication with endo. Identify problem and fix it. And also pick patient right. If they can handle open repair, do an open repair. Don't do people with bad anatomy for EVAR. Do them open. It's a better outcome. Thank you.
Thank you, Professor Mallas. Our next speaker is Professor Ashraf Mansour, again from United States, who will address to us ruptures after EVAR. Ashraf.
Thank you, Dr. Abu Rahma, and thank you for inviting me to this very nice conference. And I'm going to pick up where Dr. Mallas left off in terms of what happens after you do an endovascular aortic aneurysm repair. I don't have any disclosures in this discussion. The biggest problem with endovascular aortic repair is that approximately 1% of patients will come back with a rupture at some point in the follow-up. The CAT scan on the left shows a patient with a ruptured aneurysm with a large retroperitoneal hematoma. So the first question we ask is, what are the predisposing factors for somebody to rupture after an EVAR? We know that a very large abdominal aortic aneurysm, greater than 8 centimeters. We know that elderly patients, usually because they have tortuous arteries, We know that if you have a type 1 or type 3 endoleak, that's a predisposing factor. And then also the most important thing is graft migration. So in follow-up, you not only need to look at the size of the sac, but just the position of the endograft that you put in. Also, we know that the older prototypes for endovascular repair, such as the ANUREX, are more prone to migration. So the facts are that ruptured aortic aneurysms occur after EVAR. We know that the incidence is there. We know that the only way to detect it is by following patients closely. And then what I'll cover in a couple minutes is how do we treat this. So the benefit of EVAR is that, as Dr. Mallas has showed you, is that initially the benefit is that the mortality rate from the repair is lower. However, in the long-term follow-up, the incidence of rupture and intervention is, in my view, sometimes unacceptably high. And this is a graph from the European Journal of Surgery a few years ago, but it shows that in the beginning, 1994 and 1995, there are almost zero ruptures from EVAR. But as more and more surgeons do EVAR, the number of ruptures are increasing in the literature, and the reports about them the same. And as you can tell here, and this is just like 10 years ago, but what happens is that in the United States, over 80% of patients end up with an endovascular graft. So can we predict this? Is there a way to look at our patients and say, this patient is more likely to rupture? Well, obviously, what Dr. Mallas has pointed to is the fact that if you have a difficult neck or a hostile neck, that is probably one of the most important predisposing factors. We know also that the ruptures after endovascular repair tend to occur in the first 2 to 4 years after repair. When we look at the causes of rupture, the most common thing is that an endoleak is detected or a migration of the graft is seen. Sometimes the grafts, especially the old prototypes, will disconnect at the junction. And in some patients, either the iliac artery or the proximal neck would dilate, and that also causes failure. So when you look at all the patients that are reported about rupture after endovascular repair, you can see that every type of endoleak is implicated. But the most common types are type 1A and type 1B, obviously. That's proximal and distal. The type 1 is the highest risk, as you can see from this graph. So in one of the reports that was published a few years ago, it looked at patients that had an EVAR and the behavior of the proximal neck. And what we've seen is that the proximal neck has a tendency to dilate. And this, I think, has been an issue with us selecting the endovascular graft for patients, trying to oversize by 20% to compensate for this. Well, late rupture can happen, and this is a systematic review from the literature, and it shows that the majority of the ruptures can be, in fact, treated with another endovascular repair. And this is just a list of all the available grafts that have been talked about. And you can see at the top that the ANUREX, which is no longer available in the United States, is one of the most common grafts to cause rupture in patients. In this study that came from Britain, they followed 848 patients in their series, and they had 27 patients come in with a rupture in the average follow-up of about 5 years. And about half the patients had an open repair, and they let 15 patients expire. So when you look at the causes of rupture, or what is an indication, what is a sign that you can see in the patient and follow-up that might tell you that this patient is at high risk for potentially rupturing? Well, sac growth is the first thing. Endoleak, type 1 endoleak and type 2 endoleaks are probably the two other factors that you need to look at. So when you look at all the patients that had EVAR, roughly 80% remain stable, and about 15 to 20% will come back for a re-intervention, and as I mentioned, about 1% will rupture. So what do you do when they rupture? Well, we looked at our series. This has been updated, and we're now up to 24 patients who've presented with rupture after endovascular repair. You see that there were 14 patients, but 16 ruptures because 2 of the patients came back twice with a rupture, once on the right side and once on the left side. And you can see here, these are the types of endoleaks that we detected in these patients. And type 1 and type 2 are, type 2 actually is quite small. The numbers are quite small. So how did we fix them? In 14 patients, we were able to redo EVAR, and 2 of those patients ended up dying in follow-up. In 1 patient, we did a thrombectomy and a femoral bypass, and 1 patient was allowed to die. So the outcomes, we had 90% of the patients had another endovascular repair, but the mortality from rupture after EVAR is not 0, as you can see here. 1 of 5 patients will end up dying from a complication. And in fact, when you look at the large series, this was one of the largest series in the literature reported from the Cleveland Clinic over a long period of time. They had over 100 cases, and you can see here, these are the types of endoleaks that occur. And the infection is obviously another thing that we will talk about at some point in this conference, but the mortality is fairly significant. At 30 days, 17% of the patients will end up dying. And
Professor Mansour, less than 1 minute.
yes, sir. Summary. So to summarize, the rupture after EVAR is a recognized problem. The best option is to do another EVAR because the explantation is an operation that is quite difficult and complicated. The prognosis of these patients is a little bit worse than patients who present for elective surgery, but similar to patients who present with a rupture in the first time. The key is close surveillance is mandatory, and that surgeons should be aware of the type of endoleak that puts the patient at risk of rupture. Thank you for your attention.
Thank you very much. Can I introduce Dr. Samer Koussayer, dealing with hostile neck during EVAR, the sealing zone challenges. Dr. Samer.
Good morning, everyone. I'm going to speak about sealing zone challenging during EVAR. We know that fixation is very important in the EVAR and could be a life-saving. To get a good fixation, we need to stick to the IFU. So we need to have a length at least 10 to 15 millimeters, and angulation should be less than 60 degrees. This is a very nice meta-analysis of 7 major study in EVAR by Antonio. He compared hostile versus friendly neck anatomy. And he found that if you have a hostile neck anatomy at the neck, this will increase your type 1 endoleak about 4.5 times and increase your aneurysm-related mortality about 9 times. And another study done by Special, he looked at the influence of multiple hostile neck parameters. And he found that if you stick to the IFU, your intraoperative endoleak would be less than 1%. But if you have 2 hostile neck parameters, this will increase to 6.7%. And if you have more than 2, then this will increase to 16.7%. So what he concluded that if you have more than 1 hostile neck parameter, this substantially will increase your mortality, major adverse event, intraoperative endoleak, and adjuvant procedures. So IFU is very important, but so does the neck quality. Look at the first picture at the top. It looks a very friendly neck anatomy, and we know the EVAR will work very well, even when this patient is out of IFU because the angulation more than 60. When we look at the lower picture, this patient has a hostile neck because he has a reverse taper. But if you look at the IFU, he's within IFU, and we know this patient will have some issue down the road. So the binary IFU system, it's important, but may not be the best method to assess the suitability of the EVAR. The reason why I'm going to speak about short neck. If you have a short neck less than 10 millimeter, what option? Our first option to get a more proximal sealing zone by doing chimney or FEVAR, or you create an endovascular suture line by doing endo anchors or open repair. But not all short neck is the same. We have to differentiate between the neck length and the sealing zone. The neck length is defined by the core lab. It's the length over which the neck diameter remain within the 10% of infrarenal diameter. And look here in the green area. So the first picture is a green one. It has a long neck, where the other 2, they have a short neck. But if we just look at the neck diameter, we may call short neck 2 different things. Why is that? because the sealing zone is different. What the sealing zone? The sealing zone defined as the length over which the correctly per eye view oversized stent is still circumferentially opposed against the aortic wall. So the graft still touching the wall. We're not getting 10-15% oversized, but the stent still touching the wall of the neck. And we can see it here in the yellow area. So in the first one, here you can see patient has an adequate neck because it has a long neck and long sealing zone. Where here, this two has a short neck, but the difference, this one here has a long sealing zone. So the graft expected to oppose circumferentially in hostile sealing zone, where here we have a short sealing zone. So the graft will expect to have limit or not even circumferential opposition with the wall of the aorta. Why is that important? Because it's completely different. When you have a patient with a long sealing zone and long neck, then we have an adequate neck, so we get the good seal. If you have a short neck and long sealing zone, we get a seal, but the seal is very weak, so we have to do something else. Where this one, we have a short neck and short sealing zone, we don't have an adequate neck, then we have to get more sealing by doing something else. Give you an example, like this patient, he has a neck which is 20 millimeters length, which is very good, and sealing zone 25. So this patient has an adequate neck, so we just have to do a straight EVAR. Where this patient has a short neck 4 millimeter, but look at the sealing 10 millimeters. So this one, EVAR will give us a seal, but seal is very weak, so we need to strengthen our sealing by doing an endo anchors. How does the endo anchors work? It's create the stability of the surgical anastomosis by providing a transmural fixation of the endograft to the aortic wall. And you can see here, it gives us a very strong longitudinal fixation and give us also radial fixation, which prevent separation of the graft during dilatation of the aortic neck. What about this third patient? This patient has a short neck 3 millimeter, but also sealing zone 5 millimeter. So this one, EVAR will not work. We need to get a new sealing zone. So we need to get 15 millimeter sealing zone. So what option we have? We can go with the EVAR or you can go with the PVAR. How we decide? Of course, EVAR is a custom made. It's more concentrated technology, but the disadvantage is need more accurate planning. It takes a time, it's more expensive. Whereas EVAR is off the shelf, it's good for emergency, technically easier, but the problem is the gutter leaks and the graft conflict, especially if you have a narrow aorta. And if you decide to do a EVAR to get a good outcome, you have to stick to two rules. First, you need at least 2 millimeter minimum infrarenal aortic neck, and the new sealing zone should be at least 15 to 20 millimeters. So if you use one chimney, the new landing sealing zone should be measured from the proximal AAA to the highest renal. If you do two chimney, this will be measured from proximal aspect of AAA to the SMA. Of course, you need to oversize also 30% when you do a EVAR. So in summary, if you have an adequate neck, then EVAR will work perfect. If you have a hostile neck, which that means short neck but long sealing zone, then you can do an ESR, which is an endo anchors. If you have a short neck with a short sealing zone, then you need to get more length as I'm doing EVAR or PVAR. So conclusion, hostile neck is amongst the commonest cause for reintervention after EVAR, but in experienced center, AAA with a hostile neck are manageable with conventional EVAR, but you need to do additional tools like chimney, endo anchors, PVAR or FEVAR. But you have to understand the sealing zone to pick up your right tools. And if you have more unfavorable anatomy, always watch out. And don't forget that open repair is always an option, especially in young patients. Thank you very much.
Thank you, Dr. Salman. Next speaker, Professor Fadi Haddad, talking about open aortic surgery, suprarenal clamping, cost effectiveness.
Good morning. Thank you again, and nice flowing program leading right where we want to be. We're going to discuss aortic suprarenal clamping outcome in the era of complex EVAR. And by definition that was discussed already, we're talking about people on whom we need to do a suprarenal clamping, but the final repair is going to be in the infrarenal aorta. Rationale, there's a hype today about pushing the envelope, working outside the IFU, and this was demonstrated nicely by the previous speaker, leading to higher aortic event, endoleak, and mortality. Many cases are done now pushing the boundaries even further, and instead of doing the suprarenal clamping, going to EVAR or FEVAR.